Hi, Nicole. I have sent you the YouTube link.
Yes, I just got it. Thank you very much, Chandra.
Yeah.
Chandra sir, I have sent you the Facebook as well. Please check.
Can you just post it in the message chat box?
Okay.
Yeah.
Good afternoon. Good afternoon, Dr. Chandrasekhar.
Good afternoon, madam.
Good afternoon, madam.
Good afternoon, Vamshi.
Good afternoon, ma'am.
Good afternoon.
Okay. So I think it's exact 2. We will start. Already we have around 62 people and participants keep on joining as they register.
I'm sure most of you will be on YouTube and Facebook, right?
Yeah.
Yes.
Okay. Welcome to the International Webinar Series of IAPHD Series 2. And it was a great to be here, to have Dr. Habib here. And it has been, 2 to 3 months of our communication with him, and ultimately we got him. And you can see behind him the world map behind him. So it's very difficult to locate him actually. So somehow we were able to pin him to a location and then got him. So welcome Dr. Pushpanjali Krishnappa, the IAPHD President, Secretary Dr. Vamshi Krishna Reddy, and we have senior members Dr. S.S. Hiramet. I would like to, and all other participants who are in the YouTube and also in Facebook and live in this session Zoom platform. I would request Dr. Pushpanjali Madam to welcome the gathering.
Thank you, Dr. Chandrasekhar. Namaskara to all. Vakratunda Mahakaya Suryakoti Samaprabha Nirvignam Kurume Deva Sarvakayeshu Sarvada, seeking the blessings of Almighty on this very, very auspicious day in the southern part of India. We are celebrating Lakshmi Puja, and it gives me great pleasure to extend welcome to all the members who have registered. Indeed, this is going to be a very, very important session. Thanks to Dr. Chandrasekhar. The title itself looks very exciting to me. The transformative power of dental public health. Yes, we all know how powerful the subject is, and we are curious to know how we can make a difference and what is that additional transformative power that we all have. And thank you so much to Dr. Habib Benzian. I'm told Dr. Chandrasekhar did mention that you have gone extra mile to prepare exclusively for this particular session. Thank you very much for that, Dr. Habib, and a hearty welcome to you. Dr. Habib?
Thank you so much. Thank you so much for this warm welcome. It's really a privilege to be back speaking for your association. And the first time I was speaking on a meeting of your group was in 2013 in Lucknow, and I have fond memories of that. And it was also Chandra who brought me there, and we have been friends and colleagues ever since. So it's great to see your association thriving and being so vibrant as it is. The many people on this webinar are testimony to that. I checked your website and read your proceedings. It's quite impressive. There's not many comparable associations around the world. So congratulations to you and your achievements.
Thank you so much, Dr. Habib. Welcome again, once again to you, and welcome to all our senior office bearers who are present here. All our esteemed members who are present here. Welcome to our secretary also, Dr. Vamshi, who has put a lot of efforts to put up this session. Welcome to our scientific chair, Dr. Chandra. Welcome to all the external members. I'm told Dr. Habib has invited his friends to be part of this session. Welcome to all of you and all the student members and staff members who have gathered here. Hearty welcome to you, and let us listen to the power that we all have and how can we make it a reality from Dr. Habib. May I request Dr. Vamshi to take over?
Good afternoon, one and all. Firstly, I would like to thank Dr. Habib Benzian, sir, for accepting our invitation to be part of this event. Sir, I'd like to remind you, we met in Lucknow. I was organizing secretary of the conference then in the year 2013. And once again, it is very, very happy to see you. And I welcome all the participants and all the delegates and all the friends across the globe who are participating in this webinar. And so just to apprise you, Indian Association of Public Health Dentistry was started in early 1990s. And today we have a strength of more than 2,500 members, probably one of the largest dental public health association across the globe. And the topic of today is transformative power is the one of the word that is used. I'm sure how much weight, how much potential those words will carry on our shoulders and how we take it forward. And all of our participants and across the globe, everyone are aware of the kind of work Dr. Habib Benzian is doing. Dr. Habib Benzian has been the forefront of global advocacy to end the neglect of oral health. He works at intersection of academic research, policy and practice, and senior advisor to WHO, UNICEF, and many governments across the globe. I once again welcome you, sir. I hope all our members will have a exciting and interesting questions and interactive session at the end of this program. And and the efforts of Dr. Chandrasekhar Janakram, our scientific committee chairman, to bring you in with multiple communications and successful communications with you, and with your kind gesture and accepting our invitation. Once again, I welcome you, sir. And now I will request Dr. Chandrasekhar Janakram, sir, to introduce Dr. Habib, sir, in detail and about this particular topic, and also moderate, and he will be summarizing at the end of the session. I request Dr. Chandrasekhar, sir, to take over, please.
Thank you, Dr. Vamshi. It has been a great, for us to organize this event. We had organized previously in last year and also this year. And we wanted Habib to be a first serious speaker, but due to some issues, then he was over with his work and we could not make him. Louis Cohen was the first speaker of this session. Okay, and it was great for us to also to catch up with Louis Cohen with her experience or with journey as a social scientist in oral health. And Habib, he's actually a oral surgeon, is an implantologist, and he has he's trained and he's specialist in that. But I don't know. We would like to ask him what he made him to do dental public health in 2001 in University College of London. King's College of London, and later he went on to do a PhD. And his PhD, I still remember. I had also got a thesis book on his PhD on when he was, I think, doing a PhD defense in Amsterdam. He has been, he's now currently a research professor in New York State Dental School. But, as a person, he has around 100 publications, and he's basically a person who is a collaborator where he did his, initial work with the FDI. He brought the FDI into a global platform with building an alliances with many international organizations. And he was also a co-author and also, coordinator for the Oral Health Atlas, which was one of the unique thing to bring about in a data visualization way to see about how neglected is the oral diseases, and to reach out to the policy community about how importance about oral health and oral diseases and how it affects the quality of life. And he's also one of the important contributor to the PUFA index, which most of the Indian dentists and Indian public health dentists also uses. I think he may also speak on that index, and along with Bella Monse. Bella Monse also, we had got her as a speaker in 2014 conference, and she was also one of the contributor and of the PUFA index. He's also coordinating the Fit for School, Fits right? It's Fit School, where it's a NGO where works for the oral health and other health issues, especially in the low-income countries, and his work on Indonesia, but toothbrushing and hand washing program. I think this is what is the PhD is based on. I feel that's about, and also neglect of oral diseases globally, and his footprints are everywhere in international organizations, and recently you can see it, he's coordinating the side events of UN side events, especially with oral health, trying to bring out into international platform and try to give have an integration with the NCD promotions. So we have, especially when he talked about the topic, we had issues with discussing, finalizing your topics, dental public around the world. Then we thought about oral health resolution, and then came, it took some time for us to understand and transformative power of dental public health. And that's very important for us, because in public health dentistry, especially in our scenario in IAPHD, we are trying to redefine dental public health to the current scenario, especially for Indian context, and redefine the principles of public health, dental public health practice in India. I think this version of transformative of dental public health will make us, give us insights to work on more on our definition and competencies which is required and principles. And it's all, Habib, it's your platform now. Welcome to this, and you can share your thoughts and views and experiences about your oral health and dental public health around the world, right?
Thank you so much, Chandra. It's a real privilege to be here. First, to have this beautiful introduction from you, and to hear you exaggerating about what I did and what I didn't do. But it's also good to be reminded of some things that I've forgotten already in the meantime. And of course, I recognize you from the organizing committee, from the Lucknow meeting secretary. So it's interesting that you mentioned PUFA, because we are just doing a review of the PUFA index. It was first published in 2000, and so it's time to look at the papers that have used PUFA. And actually, after our talk here with your association in India, we saw an upsurge of papers using the PUFA index. India is at the moment the leading country using the PUFA index, followed tightly by Brazil. So I encourage you to continue with PUFA and to explore its benefits. But that's a little sidekick. Let me just share my screen. So here we go. Okay, first of all, thank you again to the organizers, to the association for inviting me. It's a great honor to be speaking right after Lois Cohen, who we all adore and cherish as a landmark leader in public health, in oral public health, and as you said, Chandra, integrating social science into oral health research. This was a big achievement of hers and very few others. And it's so great to have her still around to share her experience and journey on this. My topic, the transformative power of dental public health, sounds like a praise, like I'm going to cherish dental public health. Of course I will do, and I'm the first to promote public health and dental public health to anyone who wants to hear about it. But I think we also need to step back. We need to step back sometime as well to reflect on our practice, on our thinking, on our concepts. And I think that this point in time is a very crucial one, with so many things happening in the oral health arena globally, many countries around the world. So I think it's very opportune to think about some areas where we can perhaps change, evolve, renew our thinking, and reconfirm our broad directions. So my talk will be raising a lot of questions, and I look forward to the discussion. And I know from Chandra that this type of reflection and discussion falls on fertile ground with the members of your association. So I really look forward to the discussion. So a little bit of praise, of course, about dental public health. We often work between science, policy, and implementation in an ideal scenario. We are helping to translate evidence into practice. We are able to design effective interventions, services. And through all of this, we can make a positive impact on public health and well-being of populations. We are guided by the desire to improve equity, inclusiveness, and effectiveness. We are oftentimes innovating, and we can be very powerful in our advocacy work. My question to you is this all actually really happening? Or are we sometimes not really exhausting our full potential? And if so, why is that the case? What are the stumbling blocks, the roadblocks, or what restricts us from being the powerful advocates that we could be, or from doing the super relevant research that is needed at this point in time? I think there are many reasons, and it's impossible to exhaust all of this in a 45 minutes talk, but I'm going to focus on 5 areas in this context. I think we need to think about our basic understanding of epidemiology. I think we need to take a closer look at the research methodologies that we use in dental public health. We need to be very much aware of priorities and the need for improved data when it comes to oral health. A very critical area is our scientific independence and credibility, which is under fire and from many sides. And I'm going to speak about this in a bit more detail. And lastly, but not least, we need to be really effective in our interface with policy and with politics. It's not everybody's cup of tea, I know that, and that is fine, but it's a very crucial area if we want to harness the transformative power of dental public health. So let's dive right into the topic, epidemiology of consequence. You may have read some papers from Sandro Galea and colleagues. He's now Dean of Public Health at Boston University. And one of his landmark papers, he wrote about what he calls epidemiology of consequence. So traditional epidemiology looks to describe and understand the risk factors, the burden of disease. Some of the determinants describes inequalities. But it hardly goes beyond that. What he means, or what he and his colleagues understand under epidemiology of consequence, is that we focus on what matters most, that we don't lose ourselves in ramifications and ever more detail of research, but that we step back and take a broader societal look, a public health look at epidemiology and the data and findings that we as researchers develop, and look what is society relevant for the society and relevant for public health. That includes that we have, as scientists, have a role as well, not only in basic research, but in applied research and in implementation research. We need to follow programs, evaluate them, assess them properly. We need to help design proper interventions to make a better impact in society. These thoughts are not new. When you look at this diagram from Rose and colleagues that he developed in the early 90s, This is a typical, classic scenario. The key research questions, is the intervention plausible? That is basic research. And can it work? That's a part of applied research. So all of this contributes to intervention efficacy. And those are controlled conditions. The question really is, if we talk about community and population health, which is our focus as public health people, we need to see whether this intervention can work in real life. So we move on to community demonstrations, and we have plenty of interventions in oral health care and prevention where we have good data from community demonstrations. But we have very little data and information on interventions that work on large scale, because the majority of activities and ideas got stuck at the pilot stage and small demonstration projects. We all know about these ideas. They are all super well intended. They may even yield good results, but for some reason, the efforts fizzle out and the project is not sustainable and doesn't continue or changes direction. So we need to focus in the long run on large scale implementation and intervention effectiveness under real life conditions. That is a bit of uncomfortable reality that we as researchers need to get used to. I mean, the classic image is leaving the ivory tower to roll up your sleeves and get your hands dirty, so to say. But we urgently need this, because when it comes to the broader global picture, to integrating oral health into universal health coverage, we need data and we need studies that show it can work, it does work in large scale implementation. What are the conditions? What are the factors that lead to success? If we think about the research methodologies that are typically employed in oral health research, there is still a large predominance of, as I said, the basic epidemiology, which is counting teeth, counting surfaces, measuring pocket depth, maybe, hopefully, some quality of life. And I'm sure you have heard a lot of that in the previous lecture from Dr. Cohen. So I think we need to think a bit broader. And you may be aware of this summit that took place last year in October, the Behavioral and Social Science Summit, subgroup of the IDR. They considered research methodologies in oral health, and they made a very strong plea to include a broad range of disciplines and methodologies into oral health research, such as, of course, social science, behavioral science, but also economics, anthropology, social science, political science, etc., etc. We need to think broad, and we need to find areas where our research becomes relevant for other disciplines as well. Not everyone is understanding how we count teeth. Now I'll get to this point a bit later in my talk. Just a reminder, and I'm sure you have heard ample content about this from Dr. Cohen. When we think about what we take as research, what are our research questions and our research topics, the question of priorities comes up. And of course, we have now a global momentum towards certain objectives. And some of you may have seen the draft of the first WHO Global Oral Health Strategy, which outlines 6 priority areas and 6 objectives. All of them need to be underpinned by appropriate research at some point in time. All of this thrives with data. So let me focus a little bit on data. When we wrote the Lancet papers, the Lancet series that most of you have probably seen in 2019, we had we spelled out several areas of reform for action and change. We focused, of course, on the public health importance of oral diseases, and the Lancet was a great platform to get this out to a wider biomedical and global health community. We said that addressing population needs and inequalities should be at the focus. And we focused a lot on strengthening integrated surveillance. We said that conflicts of interest need to be clarified and handled and managed effectively, and that we should focus more on translational and implementation research, evaluation of upstream policies, and of course, capacity building everywhere. And the papers on the right-hand side show you that none of this would be possible without research. Research is really at the forefront of all of these changes and reforms. And that's where I see the transformative power of oral health and oral public health research. A recent paper from Benoit Varenne from WHO and Chris Fox, the CEO of IADR, about the role of research in the oral health resolutions just a couple of weeks ago. I recommend you to take a look at this. It outlines very clearly where research plays a role in the coming years in the context of the resolution. When it comes to data, of course, we still have major gaps. We or many countries think that before doing anything, they need a full-fledged national survey following some traditional rules and thinking. Such surveys are hugely complex and very expensive, can be anything between $100,000 and $1 million or more. So is this really necessary, or are there maybe other ways to get an idea about the burden of disease and the factors that drive disease? So that's a plea for a simplified epidemiology, a more pragmatic approach to our basic epidemiology. And of course, the integration into regular disease surveillance, government-led disease surveillance is a very crucial point. WHO has been advocating a lot of new survey formats, the STEP survey, which also has an oral health module, and many, many others. The new resolution and the global action plan will outline a few avenues to improve surveillance and propose also a few indicators further down in the process. Implementation research and evaluation of programs, I mentioned that already. When we look at the global research output, the majority of papers and research is focused on high-income country context. We have a dire need for better implementation research in low and middle-income countries. We need better economic data. This is one of the mushrooming areas in oral health research. So if any of you wants to do an additional diploma or master in health economics, I can promise you a thriving career and future. We have a big need for better economic data. And when it comes to defining new benefit packages, cost effectiveness data, integration into existing health systems and insurance schemes, we cannot do this without health economists. So overall, this data helps us to translate evidence into decision and action. But for this, we also need pathways and we need platforms where we as scientists or as advocates can actually have opportunities to talk with political decision makers. It shouldn't be all in back corridors or through informal channels. I think we need more structured approaches to this exchange, and I'll get to this topic in a bit. Data, of course, and the rise of big data, so-called big data and artificial intelligence raise a lot of concerns. I put here two extremes. One is the business corporate interest in data, because they help, or they are the basis for many money-making businesses. And of course, that raises a lot of concerns with privacy and data protection. How transparent do I become as an individual? Complicated questions that need to be managed. And dental public health and public health, including the ethics experts among us, are really in demand and needed for this, and should be sitting at the table. On the other hand, this is a statement from Margaret Chan, the former WHO Director General. Her famous saying was, "What gets measured gets done." I think this is very true, but measuring alone is no guarantee for getting things done. So there are more steps involved. But still, I think this is very relevant, and we live in this continuum between those extremes, particularly in oral health. And when it comes to oral health data and the indicators that we use, I think are living now in a period of changes and transitions. As I mentioned before, we have been trained, most of us probably, that dental epidemiology means counting teeth and surfaces, measuring pocket depth, looking at bleeding, missing teeth, etc. But our indicators are changing. When we see a global shift away from the DMFT-based epidemiology, that's how I call it, to the global burden of disease-based epidemiology, which is largely driven by the Institute of Health Metrics in Seattle and their Global Burden of Disease project. You are all familiar with that. I don't need to explain to you. But of course, their thinking and the metrics that they use, metrics like DALY's, years lived with disability, or simple prevalence estimations, are very different from the DMFT-based classic traditional dental epidemiology. And this means change. This means adaptation. This means transforming our study designs and our benchmarking processes, because looking at prevalence for a certain condition is very different than looking at a DMFT value for a certain condition. We need both. They are complementary, but we should not ignore this global thrust towards the GBD data. And you see this also at the WHO level, where many of the traditional surveillance programs that WHO had for global disease surveillance have now been kind of given up or have merged with programs that are fueled or where the data comes from the GBD machinery. And thanks to this machinery, we must really acknowledge that we have for the first time data which are based on estimations for many countries, but we have data for every country in the world, for some countries even at the subnational level. And that is a very first for oral epidemiology. We need to make use of that in every dimension that we can. Moving on to this topic of our scientific independence. In the context of the Lancet papers that I mentioned already, we also reflected on the way that certain companies and industries that are producing highly processed food, sugar-sweetened beverage, unhealthy commodities are interfacing with science and public health, and how they are trying to influence public policy. And there is also evidence that some of our oral health related organizations, be it research or professional organizations, have been influenced by corporate policies. So we just need to be very, very cautious about this. We see a very complicated global picture. Of course, through globalization, we have a few companies that dominate our commodity products market. So any of these products can basically be bought everywhere. And these few companies, they also produce a few things that are beneficial for oral health. This is the red circle the red circles on these diagrams. So when we think about collaborating with these companies through their oral healthcare products that they are producing, how do we handle conflict of interest, knowing that the company does a product that is positive for oral health, but also does many other things that are detrimental and negative to health? So how do we separate those things is a very complicated and difficult question. And I don't have the complete answers to that. But if we receive sponsorship, or if we request sponsorship or public-private partnerships with some of these entities, we just have to be very, very careful and have to be very clear about our objectives and hidden agendas. And we need to work along transparent conflict of interest policies that are public, that are publicly available. And we need to spell out the process of how we deal with conflicts of interest. And that is not only on an organizational level for you as an association or for any dental association or research association, but also for us as individual researchers. It's part of our integrity that we are very clear about those potentially negative influences. And these influences are everywhere. There's a growing body of evidence for these influences. They can be very direct. They can be indirect, they can be hidden. Some industries, they set up front-end NGOs that pretend to be health promoting, but in the end are fostering and pushing through the agenda of the corporate sector. And they are influencing priority setting in research. They have very refined tactics to deflect interest and research power or resources into areas that are not contentious to them or that don't challenge them. The research methodologies can be influenced and bias can be introduced, and there's a lot of research on that. So all in all, we need stronger publicly available policies for conflicts of interest and a strong awareness that we all need to promote for ourselves, for our students, for our organizations, because otherwise we lose credibility. And losing credibility for a researcher is pretty dangerous. That can mean the end of your career. It can mean serious legal implications. And you are in trouble then if it is clear that your research is biased, that you are omitting certain results not to harm a funder. Many ways of influencing are possible. And that relates also to this area, the last area that I would like to speak on how we interface with policy and politics. Our credibility is the starting point for this. And our credibility has been challenged in the COVID-19 pandemic to the maximum. I mean, you all have gone through this. We all have seen how the COVID-related risks were really seriously impacting on dental practice, on oral healthcare around the world, mainly through the key risk of aerosol generating procedures, about the closeness between patient and providers, the surface contamination, and all the things that happen in a dental setting that make this environment particularly prone for infection. We have also seen that there was a lot of misinterpretation of science. We have seen that dental services have been among the most affected of all healthcare services. And I think in every country around the world, there was a period of time when at the early stages of the pandemic, dental services have been completely shut down or seriously limited to non-aerosol procedures and only emergency care. And we will see the fallout of this in the long run, mainly also because school oral health programs in many countries have been completely stopped and have not even restarted yet. Countries, as you know, many countries, as you know, are still keeping their schools closed in fear of further transmission. All of this helped us in some way to think through what do we consider essential during a pandemic, because that was one of the buzzwords that was flying around. Only essential services can continue during a pandemic or during a situation of high community transmission. Also, if you are an essential healthcare worker, you are entitled to some government procured support, perhaps, or some personal protective equipment. You may even be prioritized when it comes to vaccinations, or you get salary benefits, many things in different countries. The question was always, can you please mute yourself? Okay, the question was, is healthcare and dentistry essential? And of course, our dental associations around the world, and the FDI included, were promoting very much that oral healthcare is essential. I would definitely agree that oral healthcare is essential, but it doesn't mean that everything in oral healthcare, everything that we can do in modern dentistry and healthcare, oral healthcare, is essential. placing an implant or doing advanced periodontal surgery definitely is not essential in a pandemic. And that led us to reconsider this concept of essential healthcare, because it is also important to think about this when it comes to universal health coverage, because we do not need full coverage with the full spectrum of dentistry and interventions that are possible. We would like to ensure that the basics, the necessary elements of oral healthcare are available universally. So we came up with a concept of redefining urgent, basic, and essential, and of course, advanced oral care as a concept. This was a conceptual paper in the Journal of Dental Research, and it's among the top 10 most read papers, although it was just published in February. Most read papers of all times, if you check the stats at IDR. I don't want to go into further detail of this because that would mean an entire webinar just on this topic. But it's something where, again, dental public health is at the forefront of pushing agendas, of defining and clarifying, because the debate has been very messy and confused. People were using these terms without really knowing what they were talking about, or they had different definitions of what is essential or urgent care. So again, oral healthcare, yes, is definitely essential in a pandemic, but not everything in dentistry is essential. Urgent and emergency services must be available. We talked about this. We in this paper that I just mentioned, we also highlighted that for many high-income countries, this disruption of the continuity of care was a unique experience for many. And it gave them an idea of what the needs are like when, even without the pandemic, when there is no service for dental care, when there are no availability of even simple or even essential oral health care. So the pandemic, in a way, is a reminder that we really need to advance on this agenda of expanding coverage. Back to the standing and the role of science and how science and political decisions interfere. We saw plenty of alternative facts, fake news, misinformation, deliberate propaganda in certain directions. And in most countries, the scientists were the ones who were calling for clarity, for a return to evidence, for calmness. But of course, within our scientific community, there are also different fractions and different viewpoints, which is a healthy and necessary process. But when the things were really boiling hot in terms of COVID, this discussion became really complicated at times. I quote here a former director of the CDC, and he rightly says it. There is an idea on the part of some scientists that politics is dirty, and that politicians in return think that scientists are out of touch with reality, and that some of what the scientists propose is impossible to implement in the political arena. I think there's a grain of truth in this. And again, as COVID has shown, we need to overcome these stereotypes. And we need to be effective advocates, and we need to also know where our boundaries are as scientists. We are not the politicians, but we have seen a lot of impact of politics on science, where facts and evidence were misrepresented, or they were taken out of context, or where there was an unnecessary and unwarranted blame and shame game of who took the decision. So if there is an unpopular decision, like wearing masks was a complicated, complex process to get this acceptance within populations and, of course, within political decision makers. And who is to blame for negative effects? Is it the scientist? Is it the political leader who made the decision and who has the responsibility politically for it? quite complicated issues. And you are all acutely aware of all this from your own experience and context, be it in the COVID realm, but also in oral health and the long history of oral health policy, particularly in India. I think we need to rethink our paradigm. We like to think about, or we like to see evidence-based decisions. I think evidence-based decisions are rare. In reality, we should rather talk about evidence-informed decisions. An evidence-based decision only takes science into account to come to a political standpoint and direction. An evidence-informed decision takes a lot more into account, like are the resources available to implement the scientific recommendation? Are the community needs and values aligned with that political decision? Is it part of my political agenda as a decision maker to promote this, or would that be contrary to my political agenda? So there are lots of things that come into play when it's about a political decision. I think this is more or less the reality in most situations, and we need to get used to this. This is just happening as it is, as we speak, every minute in countries around the world. Our role is really to provide the best possible evidence, definitely, but we must be aware of all these other factors and things that influence decisions in the end. And that may lead to a compromise where perhaps from a scientific standpoint, we have to swallow certain things that we are not entirely happy with, but it's perhaps the best possible political compromise at this point in time. Let me close my talk with a real life example for oral health advocacy. And you have all seen it and heard it already. The WHO has passed a resolution on oral health, one in January at the Executive Committee and one in May at the World Health Assembly. And it's the first time in 14 years that oral health was on the agenda. The last time was 2007 with a resolution related to oral health. So this is quite something. And it's not just a simple resolution, it's actually the starting point for a longer process, a process that for the next decade until 2031. The plan is that next year, a global strategy will be adopted, a WHO global oral health strategy that outlines some fundamental principles, takes stock of where oral health roughly stands in the world at the moment in global health, and outlines priorities and objectives for action at the country level. The next step will be a year later, a global action plan, which is more tangible and more actionable, with very clear recommendations and options, a policy menu to choose from for member states. And the last part of the puzzle will be a monitoring framework. Again, what gets measured gets done. This is what the resolution recognizes. We have to track progress of the implementation of these policies on the country level and on the global level. And to this end, there will be a monitoring framework established, aligned with the chronic disease framework that WHO and member states already have in place, and the majority of countries are already following. So on the occasion of the adoption of the resolution, the WHO Director General really recognized that oral health has been overlooked for too long in the global health agenda, which in itself is a very bold statement that we do not hear often from senior officials at WHO. He really emphasized that it is a public health, oral diseases are a public health challenge, and that they need to be repositioned in the global health, broader oral health, global health arena, and in the context of universal health coverage. So these are very important words and quotes that we need to keep in mind for the coming years. So again, dental public health, oral health research at the forefront. When it comes to monitoring progress of an oral health action plan, What would be our ideal indicators? What metrics should we use? Which areas can be monitored in a realistic way? Where can we see progress in a short period of time? What could be quick wins? What are more long-term things to look at and measure? So these are important questions that we need to think about. And this is a relatively open and participatory process. The first draft of the global strategy is out for public consultation, and every organization and institution, universities are invited to comment on this draft. Anyone from civil society to governments can give input into the process until September 17. So in conclusion, let me summarize and move over to the discussion, perhaps. Our key messages. We need to think about reset the priorities in research so that they are really matching a public interest. We need to be open and embrace new methodologies and metrics. We need to have in mind the global policy context, and in particular, all these new initiatives that I just mentioned at the global level. We need to help making them a reality on the country, in the country context. We need to be very strong and independent from commercial and other interests. That is the foundation for our credibility and for our role in advocacy. So real life implementation and action, advising policy and politics with a strong focus on achieving and improving health equity. Let me finish with a quote from another WHO director. Actually, I see that I quote plenty of WHO directors. The late Korean director, 2005, he said that health work teaches us with great rigor that action without knowledge is wasted effort, just as knowledge without action is a wasted resource. And I think this is very, very pertinent for us in dental public health and dental public health research. And that's the foundation for our transformative power. So I thank you for your attention and look forward to the discussion. Thank you.
Thank you so much. It was a great, indeed, thought-provoking issues which you had brought about, and you say about how these issues may transform the dental public health scenario in the future, especially with the. I'm really interested to have a few discussion on this. You talked about evidence-based informed decision, and you say that the present research methodologies are redundant because it's not. We are looking at only a small population or a controlled environment, but we have a rating on scaling of the evidence-based information. Do we have similar to that evidence-informed decision? How do we scale or grade or recommend? Because it's two complexities and so many transdisciplinary things are there. And how do I say that a decision in US of mask was a grade, or it was a best informed decision at that time and compared to an Indian situation there?
Very complicated and very complex and really challenging. I mean, this example of mask is really interesting. When you see at the early stages of the pandemic in most of the Western countries, there was a reluctance to accept masks because masks are not part of a public culture of wearing them in public. There was almost resistance in many places. And we saw accordingly that the science was not up to date with the science of masks. So we had public health institutions recommending no need for masks because they don't help anyhow, or the evidence is low for if it's not an FFP2 mask. So why promote them? And you see how science has evolved over the course of the pandemic, knowing that it's not one measure alone that will help to mitigate this pandemic, but we need a set of measures, and each of them contributes a little bit more to preventing infection. And even a mask that is a cloth mask can be part of that scenario, that continuum of prevention. So I think we like to believe that our science is unshakable and always right and solid, but in fact it is not. We always have to challenge ourselves. Yes, we have sophisticated systems of grading and rating evidence. We have complex methodologies and framework to assess the relevance and quality of evidence, and they are necessary. We need them, but they are one interpretation or one side of the reality. There is the other reality. You have to make your science accessible, understandable, and translatable. It has to be realistic for the situation that the population or your target group of intervention faces. It's not a one-to-one translation, and that's why we have translational science, because evidence does not automatically mean we know how to do it in real life.
Yeah. So you mean to say that we need to redefine our curriculum, especially teaching epidemiology, that we need research methodology, we need political science, we may need social sciences to make it how the research design should be, including all those things to make sure that evidence is generated, holistically for that particular situation.
That would be a dream if we could achieve that. But I think most of our curricula nowadays are competency driven. So if we first and foremost define the competencies that we would like to have a future professional to be able to employ in his or her work, then we figure out what is the input and the discipline and the methodologies that they need in order to get these competencies and be able to apply them to their real life context. I think public health in general, I always have been advocating for, when you start dentistry, it looks like a very straightforward career path. You graduate, you may be doing another specialty, a clinical discipline or so, and then you are a dentist and you remain a dentist. But in public health, I think the more you see, the more different things you do, the better you get. The more perspectives you can incorporate into your own thinking and working. So there's no clear career path when it comes to public health, and particularly not to dental public health, because for many, this is still a niche area where they ask, well, who are they? What are they doing? What is their reason for being? Why do people choose this? So the broader our horizon is and the pool of knowledge that we can tap into, I think the better public health professionals we get and we become.
Right. Yeah. So I would like to open the session for the discussion. Open the session, and if somebody has any questions, please unmute and ask directly. Dr. Vikrant Mohanty, the question which he had posted in the chat box: evidence-informed decisions would be influenced by science, social, environmental, political factors. Are there any tools allow us to weigh? That was a question which he had answered previously. That one. So we don't have anything as such now. I think it's a good way to develop that. As we go further, we may have to develop on that. Yeah, Ram Prasad.
Yeah, thank you, Chandrasekhar sir. A wonderful platform. Thank you so much, sir. Dr. Habib sir, thank you so much. A real insight into what's happening currently. Very grateful and privileged to listen to you today. I had one particular query. That's in relation to the World Bank classification of economic development as per income. The World Bank has given us a classification of economic development, and that's based on income. And you have a LMI, that's a lower middle income and an upper middle income country and so on. So in your experience, have you come across any strata-based planning for countries, sir? Because you have traveled wide and you've seen a number of organizations. Is there any strata-based planning for countries, for a LMI country to move into a UMI country oral health standard? Any insights or suggestions, sir, to address the gaps and deficiencies in the standards of oral health? Because we see there is a difference in standard between an LMI and a UMI country in relation to oral health. So any insights or suggestions from your vast experience, sir? Thank you so much. Thanks.
Shall I respond directly, or are we collecting questions?
You can respond. You can
okay.
Respond.
Well, thank you for this point. I think it is, many people think that there is a golden solution, one solution that fits all. Of course, that is not true. Nothing fits everyone, and everything is happening locally and nationally. And this World Bank income classification is a very, very rough comb, so to say. It can be helpful in certain circumstances, but it is not explaining everything or helping us to understand all the differences between countries and their systems, their economic development, their history, their culture, etc. So countries, even within the same income group per World Bank, may be very, very different in their understanding of health, in the setup of their health system. So it is more helping in a more general category thinking to say, okay, this country, middle income countries or upper middle income countries, for example, spend a certain amount on healthcare, and among that on oral healthcare as an average. But it doesn't really help us to classify countries. Healthcare systems have evolved historically along different lines, and this classification of the World Bank came later, and is kind of, we try to match it sometimes. And for some of our epidemiology, it's maybe helpful to see burden of disease related to country income groups, and we can gain some insights from that. But in the end, the healthcare systems can be so different. I mean, we have other ways of classifying other than the income. We have the Human Development Index. We have the GBD Social Development Index. We have other things like the Gini Index, looking at inequalities. Look at Bhutan and its Gross Happiness Index. And many countries trying to embrace the social and wellness aspects as well that go way beyond the pure health indicators or expenditure indicators. So I think it's a hugely complicated area, and we can try to define some very basic common ground that every healthcare system should be able to provide to its citizens. And that is part of, let's say, a global WHO strategy. It cannot go into any further detail because it has to be applicable to all countries. And what comes on top of that has to be defined locally and nationally.
Okay. There's a question in a chat box from Sanjay Singh. Does propaganda help in transferring the knowledge into real life action modifications?
Thank you for this question. What do you mean by propaganda? Propaganda for me has a slightly negative connotation, like you are forcing something in people's minds that is maybe correct or not. So if you talk about health education or mass media for behavior interventions, if that's the direction of your question, I think we have knowledge, or we have evidence that there are limitations to this. Some things can work through mass media communications, but many other things do not work and only have very limited time-bound effects, and the effects disappear very soon. I think the whole rise and renaissance of the social determinants discussion and commercial determinants discussion has shown us that there are so many other factors than just knowledge that influence our behavior, be it our behavior as consumers, our behavior as in a social context, in families, and our own health and hygiene behavior. So the focus has really shifted in recent years on those determinants and on creating an environment where everybody is in the first place able and capacitated to make better choices. If the choices are not available, or your income is too low to buy the healthy food, or you have no proper water sanitation at home, how can you improve your health and grooming habits? So those are the elements that we should focus on, I think, rather than perpetuating our older concepts of health education comes first and people make their own choices. Yes, they do their own choices, but they don't do them always because we have told them so.
I think what Sanjay Singh was mentioning, maybe thought was activism role in transferring the knowledge to the real life action, rather than a propaganda.
Well, activism, of course, if you see this like we need to include civil society and communities, I would definitely wholeheartedly agree, because that is an area that also in the Lancet series we recognize as a complete gap in our work. Look at any other medical field. You have patient groups organizing themselves. You have parents of autistic children organizing themselves. You have groups of diabetic patients providing self-help to each other, or trying to lobby for certain political positions or changes in the healthcare system. But there's not a single organization of people affected by oral disease, except perhaps oral cancer. But have you ever seen a group that talks about, I have a cavity, how do I live with a cavity? It's unheard of. But unless we have this, I think we are lacking a crucial pillar of our transformative power that public health has. We see in so many other areas that grassroots movements and civil society organizations can help to strengthen the argument with decision makers, and are oftentimes very powerful because those are the people that would re-elect a leader or not. So the voices of the communities count, and we have to make them count.
Yeah. Is there any other questions? Yeah.
Dr. Chandra?
Yeah.
Dr. Chandra, if there is time, I have one question.
Sure.
Probably Dr. Habib can address Dr. Vikrant's question, which is in the chat box. I will go for the last one.
Yeah. I think Vikrant Mohanty, can you unmute and
Yeah. Good afternoon, Dr. Chandrasekhar. Good afternoon, Professor Habib. I'm sorry, actually, I was trying to use the chat box because of the background noise.
Okay.
My question was, Professor Habib, we've been using dentist population ratio as an indicator for human resource planning most of the times, and even not planning, but at least looking at it. But in India, because of the large number of available dental professionals as of now, we are still challenged because we just have this indicator and we still don't have any information about this with regard to their exact distribution as of date. We have a total number. So what do you suggest when it comes to the utilization of such indicators, or are there any new indicators that are being considered in the action plan ahead in the resolution?
Thank you. Yes, that's a great question. And workforce planning in oral health is a topic that has been around for ever since we talk about dentists, basically. And it's not an easy topic, very clearly. And the insights from the past and previous concepts have shed some light on what works and what does not work. Of course, first of all, you need to know how many dentists and oral health professionals you have. That in itself is a big challenge, as you say. A dental association may know how many members it has, but there's never the exhaustive number of actually practicing dentists or professionals. Some are retired, some are on leave, some are doing something else. So, and then you have national councils and registries and licensing bodies who have, again, other numbers. So I don't think any country has the exact number of dentists. That is a challenge number one. The second one is that we have for a long time been believing or living with the assumption that a dentist treats a certain number of patients, and we have in return certain health outcomes. Research over decades has shown that there is no correlation between the level of disease burden, the status of oral health, and the number of professionals that are actually providing services. So that shows that health services, and in particular oral health services, are just one part of the bigger puzzle of health outcomes and burden of disease. And again, that brings me back to the social determinants discussion. We know, and there are estimations to what extent social determinants actually contribute to health status. Some say it's 2/3, some say it's less, some say it's less, then it's genetics and personal constitution, many other things that contribute to health outcomes. And oral healthcare is actually one of the smaller pieces of that puzzle. So again, a simple ratio was oftentimes or long time based on a number that was allegedly put out by WHO sometime in the 70s, like the golden ratio is 1 to 5,000 or 1 to 10,000, whatever it was, I think. And we were looking for this number, and actually WHO never said that. It somehow appeared in a publication, and then it was cited and quoted in circles, and now it floats around as a gold standard. WHO has never said something like that, and is not going to say something like this, because the number of professionals is an indicator of the strength of the service, definitely, but it's also depending on the resources and what these professionals actually do. If every professional is just scaling and polishing and not providing any fillings, just as an extreme example, the outcomes will be very different from everyone doing only extraction. So the mix of interventions is an important part, and how they are paid for, etc. So in recent years, we have seen a trend that workforce planning moves away from simple ratios to a more holistic approach, needs-based workforce planning. And WHO has set out a global strategy for health workforce till 2030. The document came out some 5 years ago, and they set out the principles of this needs-based workforce planning, because oftentimes health services were planned either simple on ratios or on normative need definition, not taking into account what the population preferences and the population needs actually were. Of course, we have huge problems, and particularly in huge countries like India, the geographical spread and even distribution of practitioners is a huge issue, and several ways have been tried to incentivize practitioners to spend at least some time of their career in a rural placement before then moving and settling into in an urban area with a more lucrative income. We also have different scenarios in countries whether there is a predominance of private practitioners or of public service, because you have, as a government, you have different levers to influence where services are provided, and you can set different incentives and regulations even on where you want to have services available or not. So this is a really complicated issue, and we can spend again a full webinar just on this topic. But again, as I said, the simple population to provider ratio is no longer valid.
Thank you so much.
Thank you so much, Professor.
I have Dr. Ravi Shirhatti here who raised the hand. Can you unmute and speak?
Hello, sir. Am I audible?
Yes.
Yeah. Thank you, sir, for that informative lecture. You mentioned that dentistry as such, when a dentist becomes a public health dentist or moves to dental public health as a stream, he becomes open to ideas from different other fields. Actually, in our training in dentistry, we are already during our graduation, we are already in a specialized training away from the medicine. And then once we become a public health dentist, we are so much more away from the public health arena. So how would you integrate, how difficult it is to integrate a dental public health person into the public health system? Any suggestions on improvement of that? Thank you.
That's an interesting question. Of course, we have in many countries separate dental public health courses and public health courses, but in the end, I think it doesn't matter. I personally, I did a dental public health course. Others do an MPH, Master in Public Health. I think the foundations of public health are very similar, and the additional specificities that relate to oral health and dental public health are maybe one or two modules. The foundations of population versus individual care, of upstream versus downstream, those are the same. And I would not recommend, I would not like to choose, take whatever is available as a course, and whether it's a public health course or a dental public health course. In the end, as you say, it counts that we are seen and recognized as equal public health professionals among the peers of in the broader public health arena. And we see, of course, plenty of people who have had a first training in dentistry and then moved into public health and are now in leadership positions and are leading public health institutes or have political positions. So being a dentist as first training is not something that hinders you in pursuing a wider public health career, I think. What is good, even if it is a dental public health course, is that everyone is exposed to a wide range of challenges, of scenarios, of case studies, of placements, of internships, of experiences firsthand that give you an idea that our teeth and our oral system that we care for is maybe important to us, but it's not at the center of the universe. That's something we really have to recognize in a humble way as well sometimes. Other things may be more important and maybe more pressing priorities for decision makers, mother and child health, vaccinations, the basics of healthcare. And if you are living in a country where the government spends less than $50 on healthcare in total, how can you expect that another $10 are reserved for oral? We have to be realistic as well in what we can expect and ask for.
Okay. We have, yeah, madam, please proceed.
Do we have some time, Dr. Chandrasekhar?
Yeah, we have plenty of time.
Okay. Thank you, Dr. Habib. I'm so glad that for each of the questions raised by our members, you have given a very, very clear explanation and clarification. And now my question is, this is related to the oral health resolution issued by WHO. Now, as an individual, like we are all public health dentists, and we're working in academic institutions, that is the next level. And we're associated with Indian Association of Public Health Dentists at national level. So at these three levels, what actions can we take to show that, yes, we respond to the suggestions, the recommendations given by WHO? What do you suggest? Like, how can we take an action? How can we show our solidarity to the resolution? We want your guidance. Help us out as to plan.
I understand.
You might say that it needs a separate discussion, but at least give us a few tips so that we'll start working on it.
Yes, I think this is really important. And the more support this process gets on all levels, as you outline, and in the different areas, the more solid it gets anchored, and the more can we all contribute to some broader momentum that sweeps other doubting people away with it, to use that image. So I think on a local dental school course level, the first would be, if I have a student course, let's take this resolution or the draft strategy that has been published, and let's analyze it. Let's look at it. What are the components? How is it structured? And what is the process of governance that it works? How do member states, what is their role in this context? At the end of the resolution, you will also of the action of the strategy. Sorry, you will also find sections where the roles for different stakeholder groups are outlined, and academics are outlined and highlighted with some specific roles. So creating this kind of awareness first and analytical skill for students to look at policies and learn how to read them. Because in a policy, of course, a lot is between the lines, or the things that are not said are also important. So that is one part. The second level, I would think at the association level, you are able to provide comments to WHO in Geneva through this public consultation process. And your association is a big one, is an important one that carries weight internationally among the fellow associations. So definitely, if you come up with a statement of 1 or 2 pages in support, or making suggestions for change, or criticize certain things that you think they are too weak or go in the wrong direction, that is very valuable. And I can assure you that will be taken into account. You also, as an association that carries weight, you have a role with your decision makers. So your Ministry of Health, your Ministry of Education, your Ministry of Finance, your representatives at the embassies in Geneva, the Ministry of Foreign Affairs, all of those are potential counterparts to provide them with the briefing. For example, you can send the briefing to your local parliamentarian, or to your federal level, say, okay, we realize here is this resolution. This is what it would mean for us in India. This is why we think that you, as our representative in Geneva, you should help endorse this. You should help support it. Here's how we can help from our side to make this happen in India. So you are showing that you are acutely aware of what is happening in this wider global context, and you are offering your expertise and authority to support the process of implementing something. And then, of course, internationally, when you see conferences like IDR or a bigger public health meeting, and you meet your fellow peers, I would say, or in the Asia Pacific region, Asia Pacific dental meeting, or any other meeting, even FDI, you can also liaise with them, and you could also think about putting out a joint statement on this, or saying, as an association, we saw this a couple of years ago, also when something that an association took it and changed it into an association policy. So like a policy guideline or a statement that became then association actionable, so to say. So that would be also something that you could do at the association level. So these are just a few thoughts from the top of my head. Hope that helps.
Yeah.
Thank you so much.
There's a last question from Sujata Devi. Can you unmute? Sujata Devi?
Yes, sir.
Yeah, you have a question. Yeah.
Yes, sir. I just wanted to know if we can implement the system thinking approach to address the oral disease burden. I see that it's a very successful approach to healthcare delivery, but can we implement it for the oral diseases also?
Ideally, yes. I mean, the health system, the system thinking in oral health and oral health research is very much at the beginning. It's an emerging area, and there are not many papers or working groups actually thinking through a framework that would fit to oral health. There were a couple of sessions at the recent IDR meeting about this. So definitely, from a conceptual point of view, we see health system is a complicated and complex machinery with different levels, different players, stakeholders, different responsibilities, and a very strong role for the government as well. We need to be aware of all this, definitely. And then there are many factors outside of the system that of the oral health, of the healthcare system, that relate to the bigger system of health and system thinking. So I would fully encourage you to look a bit deeper into this and to see how this can become reality.
Yes, sir. Thank you so much, sir.
Fine. I think there are more further questions and people have not raised the hand. Thank you so much. If I go back and recap what you have shared your thoughts and experiences, that you identified the clear areas where you are trying, how dentistry, dental public health has to relook or redefine itself to be to be a change in a future in this generation, especially about the evidence-informed decisions, and how actually we have to think our evidences to be politically based, or political support systems should be there to and negotiate those disciplines and to take it forward. Well, I had a question regarding, just to add on to this, what you have summarized first. Does oral health mean periodontal health, or does oral health mean dental caries? Because most of the time, the global organizations thought oral health means dental caries and reduction dental caries. And dental caries was, they had one tool, fluoride, so everybody were fancy about the fluoride tool, but they neglected the periodontal disease. Now, the periodontal disease has taken mainstream. I feel it's my own experience. But the reason is all our goals were related to dental caries, never was periodontal disease. The consequence of periodontal disease was there, a tooth mortality, a dental illness, but not as periodontal disease. So how do we take it forward? Actually, does the oral health means, because as far as possible, dental caries has been stabilized, conquered in some extent in the even though there are disparities between the population within the country, but they're not worried about dental caries as such much. But where do we locate periodontal health in global health?
Yeah, that's a challenging question for closing. You're right. The focus has been, or is still, a lot on tooth decay, and that is justified just by the sheer numbers. It is the most prevalent disease of mankind, and periodontal disease depends a lot on how you define it. And again, this is a shift that comes along with the global burden of disease by defining only severe periodontal disease as a public health problem. And I think that is part of the consensus that has been, that is globally accepted. I think there's no need to create any competition or concurrence between oral diseases. For now, and for this situation that we are in at the moment, where we are trying to get out of a situation of neglect, it would be detrimental to start turf wars between different disease entities and the professional groups that promote or stand for them. I think we need to be united and bring all those different conditions together. And of course, just by the sheer numbers, we have four major ones, and that is tooth decay in primary and permanent teeth. This is severe periodontal disease, is oral cancer, and is tooth loss. So of course, we have much more. We have clefts, we have traumatic dental injury, we have mucosa diseases, etc., etc. So we should work together as a whole to get to improve the priority for oral diseases. Once we have that, I think we need to be sure that we have interventions that we can integrate into primary healthcare and universal coverage that address all diseases to some extent, to some essential level. So a benefit package that does not include anything related to periodontal health would be incomplete, as much as anything that does not cover tooth decay would be incomplete. That is also because we need to think way beyond the clinical side, because that is complex enough. We need to think about the upstream factors, and that's where the common risk factor approach comes in. If we can reduce the risk related to tobacco, to alcohol consumption, to sugar consumption, we are addressing several diseases at once, and not only oral diseases, but also other chronic non-communicable diseases. And this is our way to go. This is where we have the highest leverage at the population level, and the most impact that we can produce. And I think in this area in particular, dentistry and organized dentistry has been not active enough so far, particularly when it comes to the sugar side of things. We have known for long, and there's more than solid evidence about the effects of sugar. But the dental associations of the world have been relatively tame and quiet on this. They didn't address sugar at the same level of power and vigilance as they addressed maybe tobacco. So I'm just saying this as a general remark. Of course, different country situations are different, and there are some shining examples. And in India in particular, tobacco is a major issue, and tobacco use in various forms. And your professional bodies, you included, have taken perfect proactive action, and you are shining examples of how this can be done. So let's shift our attention, or add to our attention, the whole risk factor scenario as one of the main action areas for us as public health professionals. We care for populations, we care for big groups, and it should be our focus. How can we get this benefit and this impact for the largest number of people possible?
Thank you so much. I think to just have a closing remark, dentistry, you told me in the presentation, during a pandemic, the care was suspended for everybody, a temporary, urgent or a emergency care, and also a long-term care. But I would say not practicing dentistry during the COVID time, it's my personal communication. We stop the propagation of pandemic. We reduced, because if we are trying to do it our own regular dentistry at that point of time, maybe a short time, the infection should have been spread a lot, because we were in a high risk population. So it's a double-edged sword. One way we are cutting the care, another way we are cutting the severity of a pandemic. You may not agree with me, but this is what I feel about that. Okay, so thank you so much, Habib. It has been a great pleasure and great experience for us to know your experiential thoughts and how you view public health, and it gives us a lot of insights to our own members, how to take it forward, especially when with this World Health Resolution, and what role does IAPHD have in that resolution, and how we can take it to our own countries to make it happen. With this, thank you very much. I would like to invite Dr. Vamshi Krishna Reddy, Secretary, for the vote of thanks.
Thank you very much, Dr. Chandrasekhar sir. Firstly, I would like to thank our President, Dr. Pushpanjali Madam, under her guidance and vision, and the efforts of Scientific Committee Chair, Dr. Chandrasekhar. The proposal of international webinars was put forward in the Executive Committee, and unanimously the entire Executive Committee approved this international webinar series, and we are coming to the close of the second international webinar series, and I would like to thank all the participants who have actively participated and have raised very interesting questions during this presentation. And it is going on live in YouTube and Facebook, and many people across the globe are watching this. I thank all the viewers for this. I would like to place a special thanks for our President Emeritus, our President-elect, and all the office bearers, and a special thanks to Dr. Habib Benzian sir for accepting our invitation and giving this wonderful worthy lecture for all our members. And I would like to make an announcement. Our national conference, virtual conference, will be held in November 3rd week of this year, 2021. I request on behalf of the scientific committee and the president and entire office bearers, Dr. Habib Benzian sir, you and your associates should be part of our national virtual conference that is going to come in November 3rd week. Please accept our invitation. We are giving an advance invitation 3 months before. So please accept and be a part of it and enlighten us and help us to grow. We all will grow together under your able guidance as well. Thank you very much, sir.
Thank you. With pleasure. It's always a pleasure to be with you and to share thoughts and to learn from you as well, because your progress as an association and in terms of dental public health and public health is so tremendous, and it's great to see. Thank you, and I'm happy to be part of that.
Greetings from India once again. Thank you, sir.
Thank you.
Thank you, everyone. Thank you, everyone.